Recorded.
Well, good afternoon and welcome to ARNNL's Tuesday teleconference session. This afternoon, I'm delighted to welcome our presenter, Krista Benson. Krista is a clinical sexologist as well as a registered nurse with the Mental Health and Addictions Program at Eastern Health. She's worked as a psychiatric mental health nurse at the Waterford Hospital in the past and began her position as a clinical sexologist in 2011. Krista is a member of the American Association of Sexuality Educators, Counselors, and Therapists, as well as the Canadian Professional Association for Transgender Health. She's also the co-chair of the Eastern Health Transgender Health Committee and a member of ARNNL. Last year, she served as a consultant with the AIDS Committee of Newfoundland and Labrador to help develop a sexual health manual for seniors that was LGBTQ inclusive, the first of its kind in this province. Krista also provides sexual health training for nursing students and supervises psychology residents in clinical rotation. She also volunteers as a support group facilitator for transgender and gender questioning children and youth in the city. So we're delighted to have you here this afternoon, Krista, to help us better understand some of the appropriate and the professional terminology and language, to address the myths, and to help us reflect on the nursing role when working with gender-diverse clients.
Hello, thank you so much for the invitation to do this presentation. Working with transgender people is a part of my job that I really enjoy, and I find it very rewarding. So I'm delighted to be able to be here today to speak about it and speak particularly about the nursing role when working with gender-diverse clients. A little bit of background about me and the sexology program. So yes, I am a registered nurse, and I worked as a psychiatric nurse at the Waterford Hospital before I landed my dream job as a clinical sexologist. And the clinical sexology program, as far as I know, I don't think we have one in any of the other regional health authorities in Newfoundland. So it's just in Eastern Health. It's part of the Mental Health and Addictions Program, and it's housed at the Waterford Hospital in the outpatient department. And I see individuals and couples 18 and over with a variety of sexual and relationship issues. But I do also see some youth, particularly transgender youth, and I do a lot of work with their partners and their families. And a lot of my work that I do with the trans population is advocacy work and helping them with transitioning and really helping them to become their authentic selves, which is a really beautiful process that I really enjoy. But I do, even though I am based out of St. John's, I do accept referrals from all over the province, and I do offer telehealth conferencing and telehealth appointments for clients that are unable to travel to St. John's. So I just want to give you guys a little bit of an outline of what I'm going to talk about today. First and foremost, I'm going to talk about the definitions and the terminology related to trans health, which I think is often can be a big barrier for some people when working with the trans population because they feel like they're not up on the terminology. I'm also going to talk about the spectrum of gender identity. I'm going to talk about the common myths about gender diversity. And I'm also going to introduce you to the standards of care for working with transgender clients, which is basically like a Bible that I use as guidelines for working with the trans population, and you can actually download those online. I'm going to talk about the medical and surgical interventions that some trans people decide to use. I'm also going to talk about the access to care in Newfoundland, some of the things we're doing well and some of the things that we need to improve on. I'm going to talk about the impact of oppression and delaying treatment for trans individuals. And I'm also going to talk about what nurses need to know. So first, let's talk about the language and the terminology. And as I said, people they slip up a little bit with the language and terminology just because there's so much of it when it comes to gender diversity. And I have slipped up myself many times because there are just so many terms out there. And honestly, they keep changing, and it's sometimes very hard to keep up with them. But some basic ones that I do want to go over with you are, the first one is called sex assigned at birth. Basically, what this means is, well, we are all assigned a sex at birth, typically based on our physical characteristics, such as our genitals, our chromosomes, our DNA, and our hormone levels. So basically, when a person has an ultrasound and they're pregnant, or they give birth, what happens is an ultrasound technician or a physician will tell the person that the child is either male or female based on the outward genitals. So that's sex assigned at birth, and that's very specific. That means that an individual has a certain type of genitals, has certain hormones and chromosomes. That's very different from gender identity, which I'm going to define later on. The next term that I want to define is trans or transgender, and trans and transgender can be used interchangeably. That's an umbrella term, and is used to describe people who have a gender identity that differs from what is socially expected given their sex assigned at birth. So somebody is transgender if their sex assigned at birth is different than how they identify. And keep in mind that that's an umbrella term, and it covers any of the other labels or definitions out there. So often somebody may identify as something very different, but they will use the label trans or transgender in a general fashion. The other term here is cisgender, and basically that's a term used to describe someone whose gender identity aligns with what is expected given their sex assigned at birth. For example, I was assigned female at birth, and I identify as female, therefore I am cisgender. And the other big one that's getting a lot of attention lately is the term non-binary. And so when we try to understand what non-binary means, we have to recognize that right now in our society, we live in a system that is very dichotomous and binary. So we say you're either male or you're female, and generally we don't expect anybody to be anywhere in between those. But what non-binary says is that it rejects the idea that there is a dichotomous system out there, that you don't have to be male or female, that you can be somewhere in between, or you can be neither one of those at all. So people who identify as non-binary may identify as male or female. They may identify somewhere in the middle of that, or not on that spectrum at all. And there's a diversity of identities and expressions and terms, and I put these there, and I'm not going to identify all of them because it gets a little bit overwhelming. But I just want to acknowledge that there are so many different labels and terms out there that are coming up, and the best advice that I can give anybody who's working with a transgender individual who uses one of these terms, if you don't know what the term means, it's always great to ask the person themselves, and often they're very comfortable identifying what that means to them. And keep in mind that one of these words may be very different for one person and then the next. So, and some people reject labels altogether. So one person may call themselves, for example, gender fluid. Another person might say, no, I'm not gender fluid, I'm gender queer, for example. So it's really important to recognize that these terms vary, and they really depend on the person who you're dealing with. I do want to define some of these terms, however, because I think they're important and they come up quite a bit. The first one is gender fluid, which is there in pink down close to the bottom on the left. That basically just means a movement or flow between gender identities and expressions over a period of time or any given moment. So basically, there's flow and movement, which means that some days a person may feel very feminine, other days they may feel very masculine, and other days they may not feel like either one. Gender queer is another term, which is up at the top there, that I'd like to define, and basically all that means is it's people who experience gender in a non-binary way. So that can include gender fluid people, for example, but they don't necessarily go by that binary system of male or female. The other one that I want to define is two-spirit, which is there at the bottom in green. And that's used by North American Indigenous people to describe their experience of gender identity. It can also be used by them to describe their spiritual identity and sometimes their sexual identity as well. And the other term that I want to define is gender creative, which is there in red. And this is a term that I absolutely love. It describes children. So Basically, gender creative means a child that's expressing their gender in a way that does not conform to social expectations given the child's sex assigned at birth. So that could include a child that expresses themselves through their clothing or their interests or their play in a way that you wouldn't necessarily suspect or expect based on their sex assigned at birth. And keep in mind that just because a child is gender creative does not necessarily mean that they will grow up to be transgender or gender diverse in any way. Sometimes it's just play, and sometimes it's just an expression of themselves. But I think that term is a really beautiful one. So we've been talking about gender identity, so it's certainly time to define it. And I love this picture that I have posted here. It really describes perfectly what gender actually is. It's in the mind, it's in the brain, it's not in your underpants. It has nothing to do with your genitals, it has nothing to do with your hormone levels or your chromosomes. It has to do with how you identify yourself. So gender identity is a term that refers to our internal sense of self as male, female, both, somewhere else on the spectrum of gender, or no identification with gender at all. And gender identity can be very difficult to describe for some people. For example, I was at a conference several years ago, and I was put on the spot and asked how I knew I was female. And I couldn't come up with an answer. I said, I just know. And that is no different for transgender people. They just know as well. So asking somebody to describe how they know that they're trans or how to describe that they know that they're female or male can be very challenging. We often tend to talk about social constructs when we talk about gender identity, like how we behave, what careers we choose, how we think and how we feel about things, what type of clothing we wear. But the reality is that sometimes that has nothing to do with who we know we are as people. All right. So one of the things that can help clarify some of this is what's called the gender unicorn. This is a great little diagram that describes basically 4 different parts of identity. So the first bit up there is gender identity. You can see the little rainbow in the cloud. So what they're talking about there is the person's sense of self. So that's independent of their sex assigned at birth, and that's in the clouds, that's in their mind or their thoughts. The dots on the outside of the gender unicorn represent gender expression or presentation. So that could mean how you wear your clothes and your hair. That could mean how you behave in front of other people. If you're a child, it could mean the type of toys that you enjoy to play with. Keep in mind that gender expression is separate from gender identity. So just because a person identifies a certain way doesn't necessarily mean that their gender expression or presentation is going to match up with that. And I'll give you a great example of that. I have several clients who are in their 50s who identify as transgender women. And often they go to work dressed as males, and then they come home and they dress in female clothing because they're more comfortable that way. Their gender identity is always female, but in certain situations and contexts, they have to express themselves in a male way because, they may be afraid that they might be discriminated against at work, or they're not ready to come out to other people in the workplace. So gender expression and gender identity can be very different. Next, we've got our little DNA helix there by the genitals, and that represents the sex assigned at birth. And as we know, sex assigned at birth can be very different than gender identity. So generally, you're either assigned female, male, or you may be intersex. And then we've got 2 hearts. And they are talking about sexual attraction and romantic attraction. And it's interesting because one of the things that we do now is we actually separate sexual attraction and romantic attraction. They're both talking about sexual orientation, but sexual attraction is talking about who you are sexually attracted to, so who you would like to be sexual with. Romantic and emotional attraction is who would you like to be romantically or emotionally attached to. And they can be the same or they can be different. Something that I'd like all of you to do who are listening is just to take a moment to think about what it was like for you when you were growing up. What did you learn about being male or female? So what did you learn? How did you learn it? Where did you learn it from? Did you learn it from TV? Did you learn it from your parents? Or did you just know? And how did you express that? And where did your beliefs about gender identity come from? What would it be like for you if someone told you you are not who you say you are? And what would it be like to look in the mirror and see a face and body that doesn't fit who you know you are? And I bring this up because so many of the transgender people that I see and work with are dealing with these things. They're dealing with families, they're dealing with friends and peers or teachers or healthcare providers who are questioning them when they know who they are, they know how they feel, but are being constantly questioned about, is this real? Is it legitimate? Oh, it's just a phase. You'll grow out of it. And the other example that I say about looking in the mirror and seeing a face and body that doesn't fit. As a cisgender person myself, I don't know what that's like. I know what to expect when I look into the mirror. Can you imagine what it must be like to look in the mirror and know that that face just doesn't match who you know you really are? It's pretty profound when you think of it that way. So I'd like to talk about common myths about gender identity, and because there are lots of them. The biggest myth, of course, is that it's a disorder. So we often equate being transgender with a mental illness, or at least we have in the past, and that's certainly starting to change. One of the things that we know about human beings is that diversity is part of us. Diversity is in our DNA. Our chromosomes, our anatomy, even our hormone levels are very, very different from one person to the next, whether you're male or female or somewhere in between. So diversity is part of who we are. And in the past, we've had a long, long history of pathologizing the trans identities. So I have a picture here of the Diagnostic and Statistical Manual of Mental Disorders, and that's the 5th edition. In the 4th edition, they actually called it gender identity disorder. So they actually label it as a disorder or a mental illness that needed treatment. Now we're recognizing that actually, no, this is not a disorder. Your gender identity is not a disorder. What we see as problematic is what we call gender dysphoria. So in the DSM-5, which was released in 2013, they now call it gender dysphoria. And that's the distress that may accompany the incongruence between one's experienced or expressed gender and one's assigned gender. So we're recognizing now that when somebody's gender identity and the sex assigned at birth don't match, it can cause a lot of distress. And that's because we live in a world that is very cisgendered and very heteronormative. We don't have a lot of room or a lot of place for people who express gender dysphoria. And that's where the issues come up. That's the distress. So it's not the identity itself, it's the feelings associated with knowing that your sex assigned at birth and your gender identity don't match up. Now, in the past, when it was called a gender identity disorder, in order for anybody to get any sort of treatment, they required a psychiatric diagnosis. So that means that they'd have to be referred to a psychiatrist, which could take a couple of years to be seen. And that psychiatrist would have to diagnose the person with gender identity disorder and basically legitimize that they are who they say they are. Then after that, in order to get any sort of treatment, they would have to endure what was called the real-life experience. So basically, they had to live for 12 months dressing in the style of their preferred gender. Now, it didn't matter if you had a family at home who you hadn't disclosed your gender identity to. Didn't matter if you weren't comfortable doing this in the workplace or in public. You had to do it. So if the psychiatrist said you have to paint your fingernails red, you had to do it. If the psychiatrist said you have to shave your chest and wear certain types of clothes, you had to do that, and wear a wig or whatever. So there was a lot of jumping through hoops back then. Now that has changed completely, and we're really moving towards a more affirmative model of care that recognizes that people are who they say they are, and we don't have the right to question that. And people are experts in their own lives, and we can't be gatekeepers to healthcare. So now, because it's no longer seen as a disorder, we are able to give clients much more access to care. Myth number 2, trans people are just confused. And oh my gosh, if I had $1 for every time somebody said that to me, or it's just a phase or a fad, it's just because there's so much media attention out there now. That's why it's so popular these days. And I've heard that from healthcare professionals, I've heard that from teachers, from parents, all over the board. And the thing that I can't stress enough is transgender identity is not confusion. It's not pretending, and it's not a pathway to just being gay or a lesbian. And it's not simply wanting the societal privileges of another gender. Often people will say, oh, well, you just want to be a male because males are privileged in society, so you're going to transition to male. Some people think that it's related to trauma or sexual abuse as well, and there are no correlations there. So it's not confusion, and it's not a phase or a fad. And when somebody says that to a trans person, it completely delegitimizes their experience as an individual. And the thing that we need to remember is that a transgender identity is just as consistent and stable as the gender identity of a cisgender person. It doesn't change. And the reality is, do we really have the right to question who another person is? We are not the expert in other people's lives. We are the only expert in our own. So we really don't have that right. The other myth, children are too young to know who they are. And this is the one that causes the most controversy. People often have questions about this myth for lots of different reasons. But one thing that we know for sure is that many transgender people have described an awareness of their gender identity from a very, very young age. And often in the past, these children just didn't have the language to describe it or to understand it, and neither did the parents. One thing that we know based on the Canadian Pediatric Society is that we actually begin to develop a sense of gender between 18 and 30 months. And anyone who has young children will know that young children start expressing gender identity at a very, very young age. And often that gender identity is not guided in any sort of way. It seems to be innate. They are naturally attracted to certain things. They ask questions based on things that you might expect from their gender. They're interested in toys that are very stereotypically expected for their gender. For example, I have a 3.5-year-old at home. And being a clinical sexologist, I try to be as gender neutral as I possibly can. And I don't like to stereotype things when I'm talking about gender. And so, trying to be a proactive parent, I would bring home toys that were stereotypically associated with male and female. So, for example, she might have Barbies, but she might also have a Spider-Man. And she very clearly told me that Spider-Man was for Daddy, and she wasn't going to play with it. And in my mind, I said, oh, crap. I would love for you to be able to play with that. But she very clearly just felt like, no, that wasn't her interest. And I thought, wow, okay. So these things are very innate. I certainly didn't teach her that Spider-Man was for boys and Barbies were for girls. It was a message that she might have heard on TV or from other children. But these messages are everywhere. And they help create identity for children. Around the age of 3 to 5 is when you start seeing in young transgender children or gender creative children start to express a sense of discomfort with their assigned gender. So that's around the time that you may see a child start to feel very uncomfortable with their genitals or want to wear certain types of clothing. They might make comments about, for example, God made a mistake, or I don't want to be a boy, or I don't want to be a girl. Why can't I do this? Why can't I do that? Now, keep in mind that just because a child expresses that at that age doesn't mean that there has to be any sort of intervention. And it doesn't necessarily mean that that person is going to be transgender either. We go by what we call the watch and wait policy, so basically you listen to your child's concerns and you support them in whatever way you can, but you don't necessarily have to have any major interventions, and you watch and wait and see what happens. And keep in mind that kids will simply enjoy play or dress in any sort of way, and they're allowed to play, and we don't have to go searching for meanings behind that play. So I'd like to talk to you about the WPATH Standards of Care. WPATH stands for the World Professional Association for Transgender Health. Right now it's in its 7th edition, and it was written in 2012, and we're hoping for a new edition in 2018. And it is available online. Basically, like I said before, the WPATH Standards of Care are basically the Bible for working with the transgender population. And it's meant to be flexible guidelines for anybody who works with the transgender population. And it covers lots of different topics. You can access it at www.wpath.org, and you can actually download a full PDF version of the standards. What the standards are trying to do is they're trying to provide an affirmative approach based on informed consent. And I'll talk a little bit more about informed consent in the context of trans healthcare in a moment. But it outlines the qualifications of healthcare professionals working with gender diverse folks. And it also outlines general criteria for medical intervention, including hormones and surgery. So they're really, really great guidelines that professionals should follow. I do want to talk about the informed consent model. And there's been a real paradigm shift in how we work with transgender folks. So in the past, like I said, the healthcare professional was really like the gatekeeper. They had to believe what the transgender person said in order to provide care, and they had to make sure that the person was legitimate. Now we're recognizing that people can give informed consent to any sort of medical intervention, and we don't necessarily have the right to make decisions for the client in that way. And there is no requirement for counseling before medical intervention for transgender people. We often think that they need to go through assessments and testing and psychological counseling before medical interventions, and that actually isn't true. It can be helpful for some people if they wish to have some counseling, but it's not a requirement. So right now in Newfoundland, basically, if a transgender folk is deciding to transition and they're interested in any sort of medical intervention, like hormones, for example, they can go to their family doctor or a nurse practitioner. I'm not 100% sure if nurse practitioners can prescribe. That's something that I've had to learn about, prescribe those particular hormones. But they can go to a GP. Basically, they sign a consent form, and they have a physical examination, then they get blood work, and then they basically get a prescription. So there's no counseling required. There are no formal assessments. It can be done in up to 3 sessions with a primary care practitioner. I do want to talk a little bit about transitioning now. And transitioning, just so you know, not all trans people transition. Some people, even though they identify a certain way, are quite comfortable with their gender expression and their gender presentation, and they don't necessarily feel the need to transition in any sort of way. Other people do like to explore transitioning options. And I look at transitioning from 3 different perspectives. I look at it from a social perspective, so that could be transitioning in public or at work or at school. I look at it from a medical perspective, so that could be hormone therapy or surgeries. And I also look at transitioning from an emotional perspective as well, or a psychological perspective, and that might be exploration of identity. It can be learning to adapt to a new role in society. It can also be learning about how other people perceive you and dealing with the barriers and challenges that come with being transgender in a very heteronormative society. And transitioning can be very complicated for some people. For example, if you have concerns about fertility, even though you may want medical intervention, you may choose not to have medical intervention because it will affect your ability to have children in the future. If you don't have any family support, some people are very uncomfortable transitioning socially or medically because they feel like they will be shamed or discriminated against. The other big barrier to transitioning for many people actually is money. It is not cheap to be a transgender person in Newfoundland. Between the clothing or the wigs or the hormones or the surgeries, things can cost quite a bit. And there are lots and lots of interventions that are not covered by MCP. For example, if you are a trans woman and you'd like to have some body hair removed, you have to pay for that out of pocket, and laser or electrolysis can cost up to $150 per session, and just to get rid of a beard, it might take 8 sessions. So transitioning is not always easy financially and in other ways as well. And some people view transitioning as a lifelong process, and others view it as something that they will complete in a period of time. So everyone is different. So for social transitioning, that might include changing the name and the pronoun, that might include changing clothing or hairstyles, might also include changing the voice. So for some people, they may decide to go to speech therapy for that. Coming out and disclosure is part of social transition. They might come out at school or at work or to family members. And they also might decide to legally change their name and their gender markers as well. Medical transition. So we have lots of different options for medical transition. Some people choose to go on hormone therapy. That can be testosterone for people who are trans males, or estrogen and androgen blockers for people who are trans females. And that can be explored at any age, 16 and over, for those who desire this. And the dosages and the type of medication can change. For example, you can use testosterone patches if you're not comfortable with the injection, or you can go on lower doses so that, if you're not really comfortable with transitioning quickly, or you'd rather go at a certain pace, you can modify that. Puberty blockers, such as Lupron, are explored for prepubescent children. And basically what that does is it stops time for a period to prevent the onset of puberty. So when somebody, say the age of 12, who hasn't quite hit puberty yet, has been identifying as transgender and that's been stable for a period of time, Lupron can be prescribed to prevent the onset of puberty, and that basically buys them time, so they don't have to go through puberty that they would be uncomfortable with, and then as they get older, they can choose to go on hormone therapy if they want, or they can choose to go through the puberty of their sex assigned at birth, up to them. But it basically just stops time for a period. And with any sort of medication, there are risks and benefits, which are really important to go over with the client. And it's important to note that some of these effects are reversible, but many are not. But one thing that we know for sure is that these medical interventions can support gender affirmation and really reduce gender dysphoria. So it's a great type of treatment for those who want it. And the criteria for hormone therapy is very, very simple. And this is outlined in the WPATH standards. Basically, you need to have gender dysphoria. You need to have the capacity to make a fully informed decision. You need to be age of majority, which is 16. And if you do have any medical or mental health concerns, they should be reasonably controlled. So if you have any medical issues, you need to make sure that the hormones are not contraindicated in any sort of way. And if you do have any mental health concerns, we just need to make sure that they are relatively stable, keeping in mind, though, that it's unethical to prevent medical intervention just because somebody has a mental health concern. Just want to go over these really, really quickly, just so you have an idea of what happens when somebody goes on hormones. So expected changes with masculinizing hormones, so that's for trans males. So the things that we see are skin oiliness and acne, facial and body hair, which is typically permanent, scalp hair loss, which is permanent, but it depends on your genetics, depends on if you're prone to hair loss. Increased muscle mass and strength. Most really, really love that. They start going to the gym and start getting really buff. Body fat redistribution, so they will see that their body fat leaves the hips and the thighs and goes more to the abdomen. The periods stop. Their clitorises will enlarge, and that's permanent. And the clitoris can get as large as 2 inches long for some. There's vaginal atrophy, so dryness of the vaginal cavity and some discomfort, particularly with vaginal penetration if they choose that type of sexual expression. Their voices deepen, and that happens almost immediately, and that's really, really cool to watch when you have been seeing somebody for several months and you can see how deep their voice has gotten, and that is permanent. That doesn't go away. And of course, there are side effects associated with these medications like high cholesterol and hypertension and cardiovascular disease and elevated liver enzymes. So these things have to be monitored by regular blood work. For the females, so trans women, they will go on estrogen and also androgen blockers. So they will also see body fat redistribution. So the fat will go to the thighs and the hips. Their muscles will decrease in mass and strength. Their skin will get soft and less oily. They will notice things like a decreased sex drive and decreased spontaneous erections if they have a penis. They will notice breast growth as well, and that's permanent. That doesn't go away. And they will also notice decreased testicular volume and sperm production, which can greatly affect fertility. And that may or may not be permanent, depending on how long the person's been on hormones and the dosage. Their facial and body hair will thin, and side effects include venous thromboembolic disease, cardiovascular disease, hypertension, and elevated liver enzymes as well. So, of course, they would also need to be monitored regularly with blood work. The surgeries. So, surgeries typically are not explored until the age of 18. However, there may be some exceptions. The kinds of surgeries that are covered and that are actually available here in Newfoundland are very, very limited. And keep in mind that just because somebody is transgender doesn't necessarily mean they want to have surgery, and doesn't necessarily mean that they're uncomfortable with their body parts. So there's a lot of diversity there. But for those who do want to have surgery, it's not an elective surgery. It is medically necessary. So the criteria for surgeries is very similar to hormones. The only difference is basically you need one referral for a breast or chest surgery. You need 2 referrals for a genital surgery. And for genital surgeries, they do recommend that the person tries their best to live in their current gender, in their gender role as congruent with their gender identity, just to make sure that they're comfortable with the gender identity before the major surgery is done. Now, that's optional. It's just recommended. Okay, let's talk about access to care. And this is probably, I would have to say that talking about access to care for transgender people is probably the saddest part of my job. And the reason why is because it's often not a great story to tell. We have come a long way in Newfoundland in terms of helping clients access care, but we still really do need a long way to go. And we know that there's stigma and there's discrimination, and lack of service provider awareness often keeps trans people from accessing health specialist services. For example, I had a young trans male in my practice that I was seeing quite regularly, and he ended up with a sexually transmitted infection. And he refused to go to a doctor about it and would not go to the emergency about it. And the reason why was he was very concerned that somebody'd have to examine his genitals, which he was very uncomfortable with, and he didn't want his genitals to be labeled using female terms because he had a vagina. So he lived with a sexually transmitted infection for quite a long, long time without care because he was so uncomfortable accessing health care. back in 2016, myself and several other researchers, we did a study on trans youth aged 12 to 17, and actually it's going to be published in the Canadian Journal of Community Mental Health. And what we found, we surveyed these youth. It was a very small study, 24 in total. And what we found was that 80% of these youth said that they felt that their healthcare providers were not knowledgeable about the healthcare needs of trans people. 80% is quite a big number. And we know that when people feel that their healthcare providers don't understand them, they're less likely to access care. And 66% were uncomfortable talking to healthcare providers about their healthcare needs and about their gender identity, which I think is quite significant. But we are doing some good things here in Newfoundland, and I want to point that out. We've got trans people accessing mental health care and lots of different supports. And I will say that I have healthcare providers reaching out to me all the time, asking questions, wanting to consult, looking for resources for trans individuals. So I think that we're moving in the right direction, and people are very interested in providing culturally competent care. Hormones and androgen blockers are covered by private insurance and also by the Newfoundland Prescription Drug Plan as well. So if you are on social assistance, you can access medication, which is fabulous. And getting those prescriptions is relatively easy. People get prescriptions from their family physicians. And if not, then they tend to go to Clinic 215 down on Lamarchant Road, where we have a physician who is very, very LGBTQ friendly and very, very knowledgeable in trans health. And we also have physicians across the province who have identified themselves as providers. I can think of a few in Gander and one in Corner Brook in particular. Still have a long way to go, but we are improving for sure. We also have several gynecologists who are completing hysterectomies for trans males. Now, we have run into some problems with MCP coverage because if the person has their gender marker changed as male, MCP will come back and say, why are you performing a hysterectomy on a male? So we've had a little bit of backlash there. But it's getting covered by MCP, so that's wonderful for trans males. We also have a plastic surgeon who's completing breast augmentations for trans women. However, that's not covered by MCP, and that can be up to about $10,000. We've got pediatric and adult endocrinologists who are prescribing puberty blockers and hormones for more complicated cases. And we also have speech therapists providing voice therapy and training for trans women. And mostly for trans women, because for trans men, their voices change with their hormones, but for trans women, their voices don't change. So we are definitely moving in the right direction here. We also are able to have people's names legally changed. They can change the birth certificate at Vital Statistics. There's a little fee, but it still can be done. And your gender marker can get changed now as well. So if you're under the age of 16, you do need authorization from a guardian, but that's usually quite easy if your family is supportive. You do need to have they call it a completed statement, but actually it's just a signature from a physician or a psychologist, a nurse practitioner, a registered nurse, or a social worker. Registered nurses and nurse practitioners can provide these signatures. Basically, they just say that, yes, this person is who they say they are, and they can get their gender marker changed. So we've been doing great things here in Newfoundland. So a few things that need to change, though, that I want to point out. That we do have a few problems with MCP coverage. The biggest problem right now is that if anybody wants to get an actual surgery, they have to fly all the way to Ontario and go to the Centre of Addictions and Mental Health to get approved for surgery. So they have to go through an assessment. And that's really problematic. First, they don't necessarily cover the travel expenses for the assessment. They will cover the assessment, but not the travel. Second, it really goes against our informed consent model of care. So basically, people who want these surgeries still have to get assessed, and that really goes against the WPATH standards of care. So we're working really hard to get that changed here in the province. It's been changed in every other province except for Saskatchewan. So we are a little bit behind there. We also have surgeries and other gender-affirming interventions that are not covered. For example, if you are a trans woman and you would like to have a vaginoplasty or a creation of a vagina, you can get that done and get it covered. If you are a trans man and you would like a phalloplasty, which is the creation of a penis, that is not covered. So why that is, we don't know, but they're very selective about what surgeries they actually choose to cover. The other big problem that we have is that private surgeons are not covered by MCP. It must be publicly funded. Well, guess what? We don't have any publicly funded private plastic surgeons who are doing genital surgeries in Canada. You have to go to a private surgeon to get genital surgery, and that's not covered by MCP. So to this day, and I've been working with trans folks now for about 6 years, I do not know one person who's had a genital surgery covered by MCP, but yet it's supposedly covered. So we also don't have a centralized gender wellness clinic like other provinces have. So we don't have a one-stop shop kind of place that people can go where they can access trans-friendly health care and mental health services. And the other big problem is that most services that we do have are centralized in St. John's and not across the province. And many primary care practitioners are still not prescribing medication. They just basically say, I'm not comfortable, I can't do that. And sometimes are not willing to help the person find a physician or another healthcare professional that is comfortable prescribing. I want to talk a little bit about the impacts of delaying treatment now, and I wasn't sure if I should post this picture or not, and so tell me again which is wrong. And so we've got a young female who looks very upset and sad, and you can tell that she's been self-harming. And then you've got that person as a male who looks happy and content. And I want to tell you that this is exactly what I see in my practice. When I see somebody who is prevented from transitioning and prevented from being their true self, I see that girl. I see that dark, unhappy, miserable person who's depressed and suicidal and self-harming. That's what I see. Not everybody is like that, of course, but that is the picture of delaying treatment for some trans people who need treatment. So I wanted to post that there for you to see because I think it's very profound. So basically, the thing that I want to say here is that delaying transition is not always a neutral option. When somebody is saying that they need treatment, that they need help, it is a bigger risk to deny them of that than to give it to them. And when somebody is needing help with their mental health and they also need a referral for medical treatment like hormone therapy, it's best to do those things at the same time. You don't wait for them to get better in terms of their depression or their anxiety or their suicidality. You treat them both at the same time, because what we know for a fact is that mental health will improve when they get treatment for gender identity. And I can attest to that. I've seen that. And the other thing that we know for sure is that when people have access to care and when they have family support, their mental health greatly, greatly improves. Impacts of oppression and discrimination. Often trans people feel invisible in our world, and that's because there's an assumption that we live in a heteronormative or cisgender world. So they're often subject to minority stress. And that can be higher rates of victimization and violence with families and schools and communities. And I have seen lots of violence in my practice. I have seen clients be fired from jobs after they disclose their identity. I've seen people be denied entry into the military because even though they were identifying as a trans male, they still had a vagina. Therefore, they were prone to being raped, so they weren't allowed to enter into the military. I have seen teachers purposely use the wrong names for students for no reason at all, just because they can. And I have seen people be told that they're going to grow out of it, and therefore they can't have hormone treatment or any other intervention. I've also seen financial barriers as well, as I spoke about earlier. So there are a lot of issues out there that cause oppression and discrimination. And there's lots of, unfortunately, sadly, there's transphobia. And I think that we have seen quite a bit of transphobia, particularly since Donald Trump came into power. He recently made a decision about the military that he wasn't going to have any transgender people be part of the U.S. military. So we're seeing transphobia and we're seeing aggression in lots of different ways. But sometimes transphobia can become internalized, and trans people can feel shame, and they can feel silenced, and they can feel isolated because of the fact that they're transgender. And the mental health impacts are huge. And keep in mind that people who are transgender are not always prone to mental health issues, but sometimes because of the way they're treated in society, it can cause mental health issues. I've seen social anxiety in particular. They worry about how others are perceiving them, or being outed in public, or being harassed, or even being sexualized by people. I have seen trauma. People have been physically attacked, or even asked inappropriate questions about their body parts and about what surgeries they've had that are really, really private and personal and, quite frankly, nobody's business. Suicidality and self-harm are quite significant as well. Back in 2015, a study came out that said that 1 in 9 trans people will attempt suicide every year. That's 1 in 9. But the general population for Canadians that attempt suicide is 1 in 167. So 1 in 9 versus 1 in 167 people. So that's pretty significant. But keep in mind that people may choose to harm themselves or complete suicide, not because there's something inherently wrong with them, but because of how they've been treated by others. Good example here is Leila Alcorn, who was a trans woman. On December 28, 2014, 17-year-old Leila Alcorn wrote a suicide note on her Tumblr blog. She revealed that her parents had refused to recognize her as a girl and had sent her to conversion therapy to convince her she was a boy. Prevented from medically transitioning, she did not believe her life would ever be worth living, and after posting her note, she walked onto a highway and brutally ended her life in the path of the tractor trailer. Her final words were, "Fix society, please." So this is a perfect illustration of what can happen when somebody is not supported by their family and when they're not supported with access to care. So, nurses, what can we do to help affirm gender identity and help people feel more comfortable and more relaxed when they're in our care? And there are lots of very simple things that we can do as nurses to provide culturally competent care. And that's really our responsibility as nurses, to make sure that we make our clients feel comfortable, and we have a responsibility to do that. And there are very simple things that we can do as nurses. The first one is creating a welcoming space. Now, I know that this can be a little bit challenging depending on what part of healthcare you work in. For example, if you work in the ER or if you work in an office building, there may be some limitations on what you can do, or there may be more opportunities. Ideally, we'd like to see gender-neutral washrooms or single-stall washrooms. Now, I recognize that in many institutions they aren't available. Sometimes it's just as simple as putting up a sign that says washroom instead of female washroom or male washroom, so that people know that they can go into either one of those washrooms. Simple things like putting up posters, rainbows, or the transgender flag. You know, if you've got an LGBTQ reference in your office or in your work area, then when people see that, they know that it signifies that the people that work in that area are LGBTQ friendly. Things to think about are referral forms, assessment and intake forms that say ask gender that's either male or female. It would be great if we could have forms that just have gender and a blank space, so that when people are actually filling those out, they can fill out in whatever way they want. The biggest thing that I can say in terms of advice for nurses is to try to take responsibility for your own knowledge. Even though a lot of trans folks are very comfortable helping healthcare providers out and educating them, it's really not their responsibility, and that can become a real burden on them. Often people will avoid seeking out healthcare because they feel burdened to educate the providers, and that can be exhausting over time. So we are expected to provide culturally competent care. So, it's important for us to look up these things and seek out the knowledge. Fairly recently at a trans youth support group meeting, there was an 11-year-old trans boy there, and he said, I asked him about this, I said, how do you feel about, the efforts that people make or the lack thereof in healthcare settings? And he said, there are those that know, those that try, and those that don't bother. And he said he's encountered all three. This is an 11-year-old boy who said this. And he said, I appreciate those that try. He said, I love those that just know. And those that don't bother, he said, unfortunately, those are the ones that I see the most. So as nurses, we cannot be those that don't bother. We have got to try our best. And I will tell you that trans folks recognize when you're trying, because I've heard it in my office. The other big thing that we need to do to validate gender identities is use the proper name and the pronoun. So even if the person hasn't legally changed their name or their pronoun, if they ask you to use a specific name and pronoun, you should be respectful of that in any way, keeping in mind that there may be some context where the person is not comfortable using that name. For example, if they're not out to their physician, if they're not out to their father, and the father happens to be in the waiting room. So you need to think about some of these things when calling out names. Often what I do is when I have a client waiting for me in a waiting room, or if I have to call them at home or leave a message, I will often just use the last name if I can, just to make sure that I'm not using a name that might make other people uncomfortable or make the client themselves uncomfortable. And really, and all that can be is, do you have a preferred name and do you have a preferred pronoun? If you do, when would you like me to use those names and pronouns? It can be a question as simple as that. And the biggest thing is, please, please, please don't dwell on a mistake. You just acknowledge it and you move on. I've made mistakes. You will make mistakes. It happens. If you make a big deal out of it, it tends to make trans people feel very uncomfortable. It's better to just say, oh gosh, sorry about that, correct yourself and move on. And that's the feedback that I've been given by trans folks. Documentation. This is another question that I get all the time from nurses, is how do I actually document this, particularly if the legal name hasn't been changed. So if your client is okay with you documenting using their chosen name and pronoun, you have to make a note of the chosen name and pronoun, and that the notes that you write will be written in this way. So I've given an example here of how I do it. So I write, this client, for example, was male assigned at birth, but identifies as trans female. Client prefers the chosen name X and female pronouns. All further documentation by this writer will respect the client's wishes. So that clarifies that the person has a specific name and pronoun that they want to use that may differ from their legal name and pronoun, and it prevents confusion. A few other tips that I can give nurses. First of all, don't assume anything at all, ever. And don't assume anything about a person's anatomy based on their physical appearance. So just because somebody may look male doesn't necessarily mean that they have a penis. They may have a vagina, for example. They may be binding their breasts under a binder. Always refrain from curious questions. Even if your heart is in the right place and you have good intentions, please remember that these questions are very personal, and if they're not necessary to the health care that you are providing, you don't need to ask. And the biggest one that I see a lot of is, well, people will ask if clients have had the surgery. When they're not actually providing any sort of health care for the genitals, they will still ask that question. And that really isn't an appropriate question, because we don't ask people what body parts they have in their pants if it's none of our business. Don't assume anything about gender. Don't assume anything about sexuality or relationships as well. You don't know somebody's history. You don't know about their sexual orientation or their gender identity. And keep in mind, though, that all healthcare should be relevant to the client's body parts, the body parts that they have. So even if a client is identifying as male, for example, they may still have a vagina. And if they have a vagina, they still need regular care for that body part. So it is the client's responsibility to look after those body parts. And we need to remember that just because a person looks a certain way doesn't mean we can make assumptions about those body parts. Keep in mind as well that those body parts may make that client feel very uncomfortable, and they may not be comfortable with the language that we might use. For example, vagina or penis, they may prefer to use other language. And if that's the case, then clarify that with the client, and you can help make them feel more comfortable. And of course, always advocate for clients when necessary. If you notice, for example, a colleague is frequently misgendering, in a constructive manner, speak up. Advocate for that person who's in your care. And I will tell you that that's the greatest gift that you can give to a client is letting them know that you're on their side and that you believe them and that you trust what they're saying, and you're there to help and be respectful in whatever way you can. So as nurses, we need to recognize the impact of minority stress and vulnerability on this population. And we need to engage in social activism when we can. Like I said, advocate for the rights of our clients in whatever way we possibly can. Be a positive role model for colleagues and the clients. And of course, never stop learning and growing as professionals. And that's the best advice that I can give you. And I thank you so much for participating today in this session. And I hope that it has informed your practice and that you've learned a lot. And you will feel more comfortable when you work with transgender people in the future, because you will work with them. They are everywhere. They are visible. They are coming to ERs. They're going for surgeries. They're using all kinds of services, and we need to be as culturally competent as we possibly can. So I hope that I provided you with a little bit of insight there. Thank you so much.